Hi, everyone. Welcome to our fifth CCRN webinar. So excited that you're here. We are going to continue through respiratory today, which I'm excited about. We got started with some anatomy and physiology last Tuesday, where we talked about intrapulmonary shunting, ventilation perfusion mismatch, the oxyhemoglobin dissociation curve, lots of kind of dense topics for the respiratory system. But I'm glad we covered it because now we're going to dive into some acute and chronic respiratory conditions that we see in the ICU. And having that knowledge base of what a ventilation perfusion mismatch is and how that relates to how we treat our patients is very important. So I'm glad we covered that. If you missed it, go back and watch it either on Facebook or YouTube. It will be helpful to understanding some of the things we're going to talk about today. Just to introduce myself, I am Rebecca. I have been an ICU nurse for about 6 years, specialized mostly in cardiac care for the first few years, but have been in more of a general ICU since then, gaining some good, more broad experience. And we are here at Archer Review, we are starting a CCRN product to help ICU nurses prepare to take the CCRN certification exam. If you're not super familiar with the CCRN, it stands for Critical Care Registered Nurse, and it's a certification that you can obtain through the AACN, is the certification board that gives this certification. So, in order to become certified, you must be a ICU nurse working. There's some option for full-time if you work in the ICU for about a year. That will give you enough hours to sit for the exam. If you're not full-time, then you can achieve those hours over more years, 2 to 5 years. So there's lots of different options to become certified, regardless of how frequently you work. Once you have reached that hour goal of experience, you're able to sit for the exam, and you will take about 150 questions total, but only 125 of those will count. You need 83 correct to pass the exam, which comes out to about a 67% score. Now, that's not a crazy high score. I mention this every single time, just to emphasize the pass rate for the CCRN is only 81%, whereas the NCLEX first time pass rate is 87%. So the CCRN exam is considered to be difficult, and that is what inspired Archer Review to create a product for it to help current nurses prepare for the exam. Let me just check really quick. Okay, good. I just had a weird feeling that maybe I was on mute or something, and I was like, oh no. I'm sure somebody would have told me though. So yes, Archer Review is now making a product for CCRN. Why would we recommend that ICU nurses become certified? There's a lot of different motivations out there. First of all, financially, your hospital will probably reimburse you for the cost of the exam, assuming you pass. Some will reimburse you even if you don't pass, which is awesome. And then once you are certified, a lot of hospitals will pay you more per hour. They'll give a shift differential for being certified. And sometimes that can be pretty significant. Where I work now, you can make, if you work full time, you can make an extra $6,000 a year just for having your CCRN certification. If you're thinking about going back to school, maybe for nurse practitioner or CRNA, nurse anesthesia, those programs often require this certification. If they don't require it, you're just a much more competitive candidate if you have it. And then finally, a big reason why I became certified was I just wanted to stay up to date with what's going on in critical care medicine and make sure that I kind of felt confident in what I did every day. And so the act of spending all the hours to prepare for the exam really helped me learn a lot about critical care that I wouldn't have learned just from going to work, even though that we learned so much at work. Putting it alongside studying for an exam like this really helped me feel a lot more confident when I took care of my patients. And that's the ultimate goal, right? We all just want to be a little bit more confident taking care of our patients and advocating for certain things with providers, having conversations about interventions and what we're doing. I felt like I could participate a little bit more because I had just a little bit more understanding about things that I hadn't looked into yet. So preparing for the CCRN is worth it in of itself, regardless of the financial and the academic benefits that it can provide. So what is Archer Review doing to help nurses prepare for the CCRN? Right now, we're offering all of these free webinars to get through a lot of the content that you'll see on the CCRN test plan. This type of material that you'll see will also be available later on after the first of the year in an on-demand video format so that you can watch and listen to these lectures in bite-sized pieces and tackle it concept by concept on your own time. They won't be scheduled like these ones are. We're also working on a question bank and a thousand question Q bank so that you can take practice questions to help solidify this material. Like I said, we'll have those on-demand video lectures, and then we're also hoping to offer CCRN mentoring. So if you're looking to sit down with a CCRN certified nurse and talk through some concepts one-on-one, we're excited to offer that as well. All the content and all the questions will relate very closely to the test plan for the CCRN that is offered to us by the AACN. We want to make sure that we are spending time on the concepts that you are most likely to actually be asked about. So that starts here with these free webinars. So like I said, when I started the webinar, we are continuing through respiratory today. We're going to talk about acute respiratory conditions and chronic respiratory conditions. What I want to emphasize is that when we're in the ICU, we are likely to see these acute conditions, which is why I want to spend a good amount of time here. We also see chronic conditions like COPD, including emphysema and chronic bronchitis. We can see asthma. When we are treating those conditions in the ICU, though, we're usually treating them in their acute state. So because of that, when we talk through acute conditions, I'm going to talk about acute respiratory failure, ARDS, or acute respiratory distress syndrome. It's important to remember that any condition, any respiratory condition can end up in acute respiratory failure. So let's really hone in on this principle. And then some of the things that we learn here will apply to a lot of the different disease processes that we talk about throughout today's webinar. So acute respiratory failure, ARF. I have it also included here as ALF. These are technically used interchangeably. ALF means acute lung failure. I feel like I'm still hearing acute respiratory failure more than anything else in the ICU. But either way, it means a failure to maintain gas exchange leading to hypoxemia. So something has occurred. The respiratory system, the lungs are no longer doing enough to maintain our oxygen demands in the body. And our blood is now has reduced oxygen levels in it, or it's hypoxic. We're hypoxemic. We have two classes of respiratory failure. We have type 1, which is hypoxemic normocapnic respiratory failure, and type 2, which is hypoxemic hypercapnic respiratory failure. So let's define some of these terms. So either way, we are in hypoxemia. We do not have enough oxygen in the blood, which means we are seeing low PaO2 levels. Our plasma oxygen content in the arterial system is low. Now, in normocapnic respiratory failure, we are not seeing a retention of carbon dioxide. We're not hypercapnic, so we'll have normal PaCO2 levels. Our carbon dioxide levels are going to be normal. In type 2, we have that hypoxemia still, a low PaO2, but we now have high PaCO2. So we have hypercapnia or CO2 retention. Now, the cause for respiratory failure, there's a million out there, and they can be extrapulmonary, so outside of the lungs, or intrapulmonary. Some sort of inner lung injury has taken place that's leading to poor ventilation, and we're not able to meet oxygen demands. An extrapulmonary reason would maybe be sepsis, and that leads to ARDS, where we have massive non-cardiogenic pulmonary edema, and we're not able to ventilate our alveoli with so much fluid on board. That could lead to respiratory failure, even though there's maybe sepsis from some other infection somewhere else in the body. It's not an intrapulmonary source, but it's leading to this respiratory failure anyway. The main characteristics of respiratory failure, no matter the cause, we're seeing alveolar hypoventilation. There's not enough oxygen in the alveoli to meet the demands. This is usually due to the presence of fluid or secretions. Something's blocking air from inflating our alveoli and allowing for gas exchange. So we're having alveolar hypoventilation. We can also see some amount of ventilation perfusion mismatching. We talked a lot about this in that A&P course or the A&P webinar last week. This is some sort of defect, either in ventilation, so with that alveolar hypoventilation, or perfusion, or both. But either way, we're leading to hypoxemia. We're either not ventilating well, or we're not getting blood flow to the ventilated alveoli to allow for proper gas exchange. Intrapulmonary shunting is an extreme VQ mismatch. This is where we're seeing blood go to alveoli that are not ventilating, and that blood, therefore, is returning to the left side of the heart deoxygenated. That's the definition of a shunt. So it's a form of a VQ mismatch that is very common in respiratory failure, where we have poorly ventilated alveoli. Blood flow is still going to go to those alveoli, and it's just not going to participate in gas exchange, and it's going to come back to the left side of the heart and be sent out to the body deoxygenated. So what are we going to do for these patients? Diagnostically, we're going to take a look mostly at their ABG. Their plasma arterial oxygen content is going to be below 60. This is a pressure value. We like to see a normal value of above 70. We know we're in severe hypoxemia when that PaO2 is under 60. Now, if hypercapnia is present and we're in type 2 respiratory failure, we're also going to see a PaCO2 of over 45, indicating that we're retaining some carbon dioxide. Now, again, we know that carbon dioxide is an acid and it's going to affect our pH. So what do we think is going to happen to our pH if we're hypercapnic? It's going to be reduced, right? So we're going to see a reduction in pH, indicating acidosis. Now, we can also do some imaging tests for our acute respiratory failure. That's one of the first things that we do when we start to suspect this for a patient. We'll take a look at their chest x-ray, see if it looks like they have nice black spaces in their lungs, indicating ventilation, or are their lungs whited out, indicating that those alveoli are not ventilated. They are not containing air. We might also get a CT scan. The provider could do a bronchoscopy to take a look at secretions or what's really going on inside the patient's lungs. Assessment-wise, the symptoms can vary dependent on the cause of the hypoxemia, but either way, we're typically going to see our patient in respiratory distress. And I'll mention that that is an early sign of hypoxia. This restlessness, respiratory distress, the patient is still trying to get as much air in as possible. If you assess a patient in early respiratory distress, they are tachypnic, they're anxious, and they are trying to get in as much air. They're probably sitting up at the edge of the bed, trying to inflate their lungs as much as possible. Now, the problem is that gets exhausting. So we have late signs of respiratory distress, which kind of tell us, oh, we're no longer really in distress. We're now going into failure. Our respiratory system is failing. And we're going to see a reduced level of consciousness with our patients because they're exhausted. Now, if they're in type 2 respiratory failure and they're also hypercapnic and retaining CO2, a symptom of CO2 retention is lethargy or sedation. So this patient is also, they're tired because they were just breathing 50 times a minute and getting exhausted, but they're also experiencing lethargy as their respiratory rate starts to slow down and their CO2 is retained. And now we have lethargic symptoms due to hypercapnia as well as that exhaustion. So goals of management, we need to treat the underlying cause. Is this caused from a collapsed lung? Do we need to place a chest tube? Was this caused from a pulmonary embolism where we've got poor perfusion to our lungs? Do we need to handle that? Is this massive atelectasis where we have huge alveoli collapse and so those alveoli are not ventilating? Maybe we need some positive pressure ventilation for that. The goal is to improve our gas exchange. So we need to support oxygenation and ventilation to do that, which we'll talk about in depth on the next slide. In the meantime, we'd also like to correct our acidosis, which is essential for those patients in hypercapnic respiratory failure. We need to get that CO2 down to correct the acidosis. And we'll talk about other ways that even those that are not in hypercapnic respiratory failure, they could also be acidotic as well. And we'll talk about how that works. First, let's dive in a little bit further into our oxygenation and ventilation. For some of these patients, it'll be just as simple as providing them with supplemental oxygen. If their alveoli are still ventilating okay, maybe they just need some oxygen support. So if we can put a nasal cannula on or a non-rebreather temporarily to help get them to a better spot, we might be able to improve their status just with that. But if we've got secretions in the way or severe alveolar collapse, we're going to need positive pressure ventilation to open the alveoli and open the airways. So that's when we'll talk about ventilation here. The goal with oxygenation is we want to keep our pulse ox over 90%. That's a standard goal for most patients. It does vary depending on some other things that your patient might have going on. In the presence of a shunt, so this is where we have that severely collapsed alveoli that's not ventilating at all. Blood flow is still going to that alveoli for gas exchange, but it's leaving the capillary without oxygen. So we're returning to the left side of the heart with deoxygenated blood. We are going to need positive pressure ventilation. You could give that patient as much oxygen as you wanted through a non-rebreather, face mask, whatever delivery method you'd like. If that alveoli is not ventilated and air isn't getting there, the presence of oxygen is not going to make any difference. That's known as refractory hypoxemia. No matter how much oxygen we give, that patient is not responding to it, and they need positive pressure ventilation. So with ventilation, we need our client or our patient to take more breaths. In addition, we also need to open their airways, open the alveoli. In hypercapnic respiratory failure, we might have a patient who's only breathing 5 to 8 times a minute due to that CO2 retention. In that setting, we need to give them some sort of positive pressure ventilation where we can control their respiratory rate. First line therapy, we're going to use non-invasive mechanical ventilation, which this would include a BiPAP. BiPAP is preferred over CPAP when we have that CO2 retention. But if our patient is super, super lethargic and we don't think that they're able to protect their airway anymore, then it's really not appropriate to just throw a BiPAP mask on them when they're not alert at all. That is when we are going to need to intubate that patient and place them on the ventilator. That's known as invasive mechanical ventilation, which does include intubation. This ventilation support is how we're going to get that positive pressure ventilation to open the alveoli and allow for gas exchange to take place. Now, in addition to oxygenation and ventilation support, we can also use pharmacology to assist these patients. Most of the time, they are going to be on inhaled bronchodilators to relax their airways, again, allow for more air movement. Steroids can also be used to reduce airway inflammation. If we have any concern of any sort of infection in their lungs, we'll also start antibiotics for these patients. In relation to pharmacology, we also should talk about how we use pharmacology for our invasively ventilated patients or intubated patients. We need to lower the oxygen demand for these patients. If we place a breathing tube into a patient, hook them to the ventilator on a control mode, an uncomfortable mode, and we don't provide any sedation or pain control, this is going to make them very uncomfortable and very, very anxious. And we are going to spike our oxygen demand. We need to settle the system down, allow the patient to relax so that they can focus, their lungs can focus on just oxygenating the blood under low oxygen demands. Sometimes, even after we sedate and provide plenty of pain control for a patient, their lungs are still really stiff against the ventilator and they'll buck the ventilator. That's when we might need to do some neuromuscular paralysis in addition to sedation and pain control to help get the lungs to fully relax and allow the ventilator to do the work that it needs to do. I want to note that it is extremely important that we ensure proper sedation prior to paralytic administration. There's nothing more cruel than giving your patient a paralytic when they're still slightly awake. They can tell that they have received that medication and that they can't move, and it makes them feel locked in. So we must ensure that we've first tried adequate sedation. It's not enough. That doesn't mean we turn off the sedation and try the paralytic. We keep max sedation, ensure that they are at a RASS that is appropriate for paralytic administration, which would be a RASS of -4 at least. And then we're safe to give a paralytic. So I said that we were going to talk a little bit more about this acidosis pathophysiology. We talked about when we have hypercapnia present. That's going to lead to classic respiratory acidosis. We're retaining CO2, which is an acid. We're going to get an acidotic pH from that CO2 retention. Now, what if we have type 1 respiratory failure? Does that mean every single time that we don't have hypercapnia that that patient is going to be not acidotic? Actually, no. We typically are going to see those patients be acidotic as well. It's just for a different reason. They will be in a metabolic acidosis. That hypoxia leads to tissues going into anaerobic metabolism, so they're operating without enough oxygen. That will cause the release of a byproduct called lactic acid. We'll have a lactic acidosis, which is a metabolic acidosis. So hypoxemia in general, regardless of our CO2, is going to lead, if it goes on for long enough, can lead to an acidotic pH regardless, again, regardless of our CO2. Acidosis treatment, we're going to make sure that we're supporting both oxygenation and ventilation. That's typically sufficient. If we can support our ventilation and let those in type 2 respiratory failure breathe off all their CO2, we'll fix respiratory acidosis. If we can support oxygenation for those in type 1 respiratory failure and type 2, then we can help with this cascade of events leading to lactic acidosis. So oxygenation and ventilation should be sufficient to fix our acid-base imbalance. If it's not, if we are having severe acidosis with a pH under 7.2, maybe even a little bit lower, kind of depends facility to facility, we will consider bicarbonate administration just to, in the moment, help with our acidotic pH and just get it up a little bit quicker. We do kind of want to avoid this if we can. Bicarb is really just a Band-Aid to help soothe our pH, but it's not actually doing anything for our patient. We need to fix the cause. Nursing management. This is huge when it comes to respiratory failure. We play a really big role in supporting our patients' oxygenation and ventilation, regardless of what machines this patient is on, to help with those things, the oxygenation and ventilation. We can help our patient with positioning. Elevate their head of bed 30 to 45 degrees if you can, given their hemodynamics, to reduce aspiration risk and also just help with ventilation. We do operate on a good lung down principle. This is to aid in perfusion and ventilation. When we have, let's say we have an aspiration pneumonia sitting in the right lung, that's the most common lung for aspiration pneumonia. That tissue is, or that lung tissue, yeah, it's junky. It's got lots of secretions. It's not ventilating well at all. Now, instead of putting them on their right side, if we put them on their right side where all of that junky lung tissue is that's not ventilating, we're going to send perfusion more so to that right lung than our left. So we want to do good lung down. We're going to lay that patient on their left side so that the left side that's ventilating better is able to receive the most amount of blood flow. That's what's going to help our hypoxemia the most. We're sending more blood to good lung tissue so that we can get our blood oxygen content higher. We need to minimize oxygen consumption. This relates to that sedation and pain control needed for our intubated clients. For our intubated patients, for our non-intubated patients, this will revolve around clustering care. And again, just making sure pain control and sedation is all where we want it to be. Secretion management, ensuring our patients are adequately hydrated. Sometimes when there's a concern with the respiratory system, we get really, really afraid of giving these patients fluid because they already probably have fluid on their lungs. We need to make sure that they are hydrated. Oxygen support should be humidified. And we want to encourage our awake patients with a coughing and deep breathing. Let's move on to acute respiratory distress syndrome, which again, I want to point out, ARDS can turn into respiratory failure. But the pathophysiology behind ARDS is slightly different. What's happening with ARDS is we have an acute onset. That's where that acute respiratory distress syndrome comes in. Acute onset, non-cardiogenic pulmonary edema. So we have pulmonary edema, which is just fluid in the alveoli, inhibiting gas exchange from taking place, but it's not from a cardiogenic source. Let's review what cardiogenic pulmonary edema is so we can differentiate. When we have a patient in left-sided heart failure and they are not able to eject enough volume out of the left ventricle, that volume is going to begin to back up into the left atrium and then into the pulmonary system. That's going to lead to the alveolar membrane becoming leaky as there's too much pressure in the pulmonary vascular space. And we're going to get fluid passing from the bloodstream into the alveoli, leading to pulmonary edema. That's cardiogenic, though. That's due to a malfunctioning heart. In ARDS, we're talking about non-cardiogenic. Fluid is in the lungs due to some other reason, usually due to alveolar capillary membrane disruption. So that capillary is leaky. This is typically caused by systemic inflammation that is going to lead to the alveolar membrane permeability. Fluid is going to leak into the alveoli from the capillary membrane. Now, as this progresses, we are going to see even more capillary permeability. That alveoli is going to begin to scar and the tissue is going to restructure. Anytime we see remodeling of tissue, that tissue is never as good as it was in the first place. And that scarred tissue is not going to participate in gas exchange nearly as well as healthy, normal, non-scarred tissue. It's kind of like in the heart when that tissue can remodel due to myocardial infarction, that tissue doesn't carry electricity as well, it doesn't squeeze as well, and it's a reason that a lot of our patients go into different types of heart failure. The same thing exists with ARDS. And if we let this progress and that tissue starts to scar, that tissue is not going to participate in gas exchange the same way really ever again. So we have to treat ARDS quickly. What is going on at the alveolar level? In a normal, healthy alveolar membrane, we have cells that are closely packed together. They pass through one cell at a time, and gas exchange can occur very, very easily. In ARDS alveoli, our capillary membrane cells are more spread out, and this membrane is disrupted and it's leaky. This is going to cause fluid to enter the alveoli and lead to extremely poor gas exchange. So what are we going to do for these patients? We want to treat the underlying cause. Are they in systemic inflammation due to sepsis from some other infection? We need to treat that infection and treat the inflammation, all while we promote oxygenation and ventilation, just like we do for our respiratory failure patients. Our patients are going to look dyspneic and tachycardic. They might have cyanosis, either centrally or peripherally. Hypoxia, we already talked about how the early signs of hypoxia is restlessness, and the late signs we're going to see lethargy. So we need to look out for that with these patients. On auscultation, we'll always hear crackles because pulmonary edema is such a huge component of ARDS. Diagnostically, we're going to get a chest x-ray that is going to show these bilateral infiltrates or white spots. This is not good ventilation. We're not seeing a lot of airflow here. Now, our PaO2 to FiO2 ratio, this is very commonly used in diagnosing ARDS. It's a little bit of a difficult equation to explain, but basically we see a PaO2 to FiO2 or PF ratio of under 200. Normal is over 286. All this is saying is we look at our PaO2, so how much oxygen is sitting in the blood, and how much oxygen we're administering to the patient via their FiO2, and what does that number equate? And I've got an example here. If we were to draw blood gas on a patient who's receiving 80% FiO2, maybe they're on the ventilator, we've got 80% FiO2 going in, max is 100%. And even with 80% FiO2, we're sitting at a PaO2 of 55. That would be a PF ratio of 69, which is really horrible. That means we're giving this patient a ton of oxygen and we still cannot oxygenate their blood. It's just not a good sign that our tissue is very healthy. It's clearly not participating in gas exchange well. So that ABG is going to show us a hypoxemic PaO2 of under 60. PaCO2 early, it might be really low because that patient's tachypnic. They're breathing off a lot of CO2. So we might see a low CO2. Now, as they start to get exhausted, that respiratory rate slows down. They may start to retain CO2 and we'll see something above 45. So that can change as this disease process progresses. Oxygenation and ventilation, again, we can provide supplemental oxygen. It's probably not going to work. We're going to need positive pressure ventilation. We can also use positioning to help these patients. Prone positioning is very, very common. We want to increase perfusion to healthy lung tissue. It's the same principle as good lung down. We have this patient who's probably been in the hospital for a little bit before they develop ARDS, and they've been laying on their back this whole time. That means all that pulmonary edema is resting just due to gravity in the posterior portions of their lungs. We're also sending a lot of blood flow to the posterior portions of their lungs because of gravity. Now, if we flip them onto their stomach, maybe for 12, 18 hours at a time, we are going to send perfusion to healthier lung tissue that's sitting in the anterior portion of the lungs. Now, we need to flip them back to supine every now and then because if we leave them on their anterior or on their stomach, then those anterior portions are just going to fill with that pulmonary edema as gravity takes its role there. So we flip these patients back and forth to try to feed the healthier lung tissue with blood. That way we can improve our hypoxemia. Now, pharmacology, nutrition support, acidosis management, potential complications, all of that is very similar to respiratory failure. Ventilation-wise, this is typically necessary with our ARDS patients. They're going to need to be mechanically ventilated, a lot of times invasively. If somebody is in ARDS, we are likely intubating them. And this is because we want to use a setting called PEEP on the ventilator, positive end expiratory pressure. This is the amount of pressure that we're going to keep in the lungs in between breaths. So normally when you and I take a breath, we breathe in, we inflate our alveoli, we breathe out, and our alveoli collapse. There's really no pressure in the lung keeping them open, and that's okay. We've got healthy lungs that we can reinflate them for every breath. Now, we want the alveoli for a patient in ARDS to stay open for as long as possible. So we're going to use this positive end expiratory pressure to keep some pressure in the lungs after exhalation to allow the alveoli to stay open, which can increase the amount of time that gas exchange occurs, as well as just make it easier for alveoli to inflate. They don't have to go from collapsed, to inflated every single time. It's pretty helpful. This can reduce intrapulmonary shunting as we're allowing for more proper alveoli ventilation. That way, when we send blood flow to the alveoli, it's ventilated and it's going to participate in gas exchange. The blood will return to the left side of the heart oxygenated. Facilities will use ARDS ventilator protocols to help guide PEEP. They typically are going to include high levels of PEEP and low levels of low tidal volumes to prevent barotrauma. We don't want to have a ton of pressure in the lungs and then send in a huge tidal volume because we can actually then collapse alveoli due to too much pressure and causing damage on that alveoli. Really quickly, the CCRN test plan includes it. This is TRALI, transfusion-related acute lung injury. This is a form of ARDS, but it's coming from a patient receiving a blood transfusion. They experience sudden shortness of breath from massive pulmonary edema. And what's happening is the white blood cells that are in the donor's blood are attacking the recipient's white blood cells, which is going to cause a systemic inflammatory response because it's a blood transfusion. So that's all happening all over the body. It's a systemic inflammatory response that we're going to get that leaky capillary membrane, and we'll have an ARDS situation due to a transfusion-related acute lung injury. We're going to see that tachypnea with the shortness of breath. If we know that a patient is at risk for this, we're going to use leukocyte-reduced blood to just help reduce the risk. If we if that donor blood doesn't have as many white blood cells or leukocytes in it, there's not as much of a risk of them attacking the recipient's white blood cells. Okay, I see a couple of questions here. How much is the review? We actually don't have pricing for it just yet. We are going to start offering the question bank here, hopefully within the next month or so. And that will be at a very low cost, if not free. And then in the new year, that's when we're going to release the on-demand videos, and the pricing will be released closer to then. To find part one, it is, if you scroll on Facebook, it was posted last Tuesday, which makes that what, the 22nd, Tuesday, October 22nd, or you can go on YouTube and search Archer Review CCRN Respiratory Part 1, and it should pop up there for you. Okie dokie. Next, we're going to talk about pneumonia. Again, this in the ICU can quickly turn into ARDS and acute respiratory failure, either one. What's going on with pneumonia? We all should be pretty comfortable with this. We see it a lot in the ICU. We have acute lung inflammation that's caused by an infectious agent. So we had lung inflammation with ARDS, but it wasn't necessarily caused by an infectious agent. In pneumonia, it is. This can be bacteria or viral. We've got lots of different types of pneumonia. Community acquired, which is a lot of what we see when we get a patient in the first 48 hours of their admission with pneumonia, that came from the community. We can give our patients pneumonia with hospital-acquired pneumonia. That's when symptoms start after the first 48 hours of admission. Ventilator-associated pneumonia is very common. Less common now because hospitals are really focusing on making sure this doesn't happen. But it's when the presence of that artificial airway is a foreign body, and it can greatly induce the risk of pneumonia as we suction and different things from the outside are introduced deep into the airways. And then aspiration pneumonia occurs after and due to aspiration. So just a foreign substance in the lungs from eating. So management-wise, we're going to support oxygenation, support ventilation. That goes for every single respiratory disease process we'll talk about today. Hydration and nutrition support for these patients to heal properly. Therapeutic bronchoscopy may be indicated for secretion specifically, as they can be really significant in pneumonia. And pharmacology, we're definitely going to add on antibiotics in addition to any inhaled bronchodilators. Maybe a little bit of steroid. We don't love to give steroids if we know that we've got an infection present, because steroids do significantly reduce our immune response, but sometimes it is necessary. Assessment-wise, we are going to see normal respiratory symptoms with our patients. So cough, dyspnea, increased oxygen demands. We'll also see those infection components of fever and maybe confusion with our older populations. Coarse crackles due to not just fluid pulmonary edema, but actual presence of secretions. That's going to lead to a coarser crackle on auscultation. Dullness to percussion as there's consolidation present. Diagnosis-wise, we'll use a chest x-ray to see those pulmonary infiltrates. We can do a sputum study for these patients to microbe identify, and that way we're able to give them the right antibiotics. Bronchoscopy can further assess lung tissue as well as just get out all of that, those secretions like we said in management. And then we'll also see an elevated white blood cell count with these patients as they have an infectious source. Let's talk a little bit specifically about aspiration pneumonia. This is the most common aspirated contents are gastric or oropharyngeal. And not every aspiration leads to infection. I've had some speech language pathologists come in and look at my patients and they'll say, yeah, they're definitely aspirating, but due to other factors, I'm not too concerned about it. They're like, oh, this patient might be okay to aspirate a little bit. It's patients that are maybe up and moving quite a bit more. That is a huge preventative technique to aspiration pneumonia, where if they do aspirate, if they're up and moving, then those lungs are coughing and deep breathing very frequently, then the chances of that aspiration turning into an infection and a pneumonia is much slimmer. So it might be worth it for that patient to subtly aspirate every now and then if there's other reasons that we're not as concerned about it. I remember when I was talking to the speech language pathologist, the SLP, and they were explaining that to me. I just thought, oh, if there's any sign of aspirating, we just can't feed this patient. We have to use a tube or TPN or something else. And they were like, no, it's actually better for some patients to just aspirate just a little bit. But we definitely leave that decision making to the SLP, not us with our bedside swallowing screenings. Acidotic aspirations, ones that come from the stomach, are more harmful than others as that acid can tear into the lung tissue a little bit differently. Chest x-ray is the classic diagnostic tool for this, as it will show asymmetrical infiltrates, meaning that it is occurring in one location of the lungs, typically that right side, due to how the main stem bronchi come off the trachea. Nursing management wise, we are just going to emphasize aspiration prevention. So head of bed is going to be elevated at 30 to 45 degrees. We're going to frequently manage secretions with oropharynx suctioning, and then proper feeding tube placement is very important. Okay, I am going a little slower than I wanted to today, so we'll see how far we make it. Let's talk about invasive mechanical ventilation. Now, I am talking primarily to current ICU nurses that have probably played around a good amount with ventilators, as a lot of our patients in the ICU are on the ventilator. So I'm going to bear that in mind as I go through this. We're going to talk about it in detail, but again, I'm assuming that there is some baseline knowledge here. So what patients are indicated for mechanical ventilation? The primary goal of mechanical ventilation is oxygen delivery and CO2 removal. It reduces the workload of breathing because we have a tube going all the way almost to the carina of the trachea, and it's instilling air and drawing air out. It takes away the patient's responsibility to do that for themselves, and they aren't responsible for getting air from out here in the atmosphere all the way down into the deep parts of their lungs with a breathing tube that, again, is going deep into their trachea. This does allow for safe sedation administration. Sometimes we need to sedate a patient for other reasons. Their lungs and respiratory system might be totally fine, but we need to sedate them. And in order to do that safely, we might need to intubate them first for procedures, etc. It also reduces oxygen demand. As we are reducing that workload of breathing, we are reducing the amount of oxygen that those tissues need. And just as a definition, I think I skipped over this. Invasive mechanical ventilation means that the ventilator is attached to an invasive airway, so an endotracheal tube or a tracheostomy through the neck. Let's talk about ventilator settings. And then we'll talk about modes. There's two kind of categories. When we look at a ventilator, we're looking at two ways that we can describe what the ventilator is doing. And the first is settings. So we've got a respiratory rate. We can set the respiratory rate on the ventilator, specifically in control modes, and say, hey, this patient's going to breathe 16 times a minute. And we're setting that respiratory rate. So that's a ventilator setting. Another one is tidal volume. We are setting the amount of volume that anytime that ventilator gives them a breath, this is the amount of volume they're going to take in. A common protocol for this is 6 to 10 mLs per kilogram, and the respiratory therapist and provider work closely to figure that number out. We do lower tidal volumes in ARDS, which is why we have this 4 to 8 milliliters per kilogram in ARDS. Oxygen concentration. How much oxygen are we going to give this patient with every breath? This is an FiO2, a fraction of inspired oxygen, so it's a percentage, anywhere from 21% to 100%. PEEP. Positive end expiratory pressure. We already talked about this for ARDS because it's very, very important in ARDS. The baseline that we'll normally see in practice is around 5 centimeters of water. It can go as low as 3, but we're usually only going as low as 5. This is the amount of pressure that we're leaving in the lungs to keep alveoli open in between breaths. A really low PEEP like this 3 to 5 is really just enough to keep pressure in the tube. It's not really going to do much for the alveoli because it's not a high enough number to get all the way into those deep airways. Pressure support is the amount of positive pressure that is being used to assist in inhalation. Tidal volume and pressure support may or may not be present depending on what mode you're your patient is on. But these are all the various settings. There's more settings for sure, but these are the main ones that we are concerned about as the nurse. Now let's talk about modes. I think this is where things get a little bit more confusing for a lot of newer to ICU nurses that I've talked to. So the ventilator mode is how the machine works to ventilate the client. Now I break down modes into two categories. I first care about what is the trigger, and then I care about when the ventilator delivers a breath, what is it delivering that air as? So first, let's talk about the trigger. The trigger is either the machine or the client. The machine, if we have a set respiratory rate, if we said that respiratory rate was 16 breaths a minute, that patient could be completely sedated and not initiating any breaths on their own, and the machine is going to trigger 16 breaths a minute for them. Now, if we have a patient who's a little bit more awake and they're able to initiate their own breaths, we might take a set rate away. We don't need it. And now the patient is triggering their own breaths. Now, if we've got a patient who's somewhere in the middle, they're not totally awake, but they're not totally sedated either, they might get some machine-triggered breaths and some patient-triggered breaths. They're allowed to still trigger their own breaths. But the mode is going to be set to one or the other. But in those machine triggered modes, the patient is still allowed to trigger their breaths in addition to the rate that the machine is going to give them. Now, when the ventilator delivers that breath that either the machine or the patient triggered, how is it delivering it? We can either deliver a volume amount of air. So this is when you see, oh, their tidal volume is 250 mLs of air. That means every single time that patient takes a breath, whether the machine triggered it or they triggered it, they're getting 250 mLs of air. Or we can set the pressure, and that would be that pressure support number that I talked about in the settings. And we can say, instead of you're going to take 250 cc's every single time, we'll say we're going to give you a pressure of 15 to help you take a certain amount of tidal volume. And then the tidal volume itself is going to vary with how those lungs respond to getting that amount of pressure. So those are the two ways that the ventilator can deliver breaths, either a set tidal volume and an amount, or a set pressure, and the lungs can determine how much volume they actually take. I've included some main ventilator modes here. Up on this side, we have machine triggered modes, and on this side, we have client or patient triggered modes. Up here, we have our volume modes that can be machine or client triggered. And here we have our pressure modes that can be machine or patient triggered. So first of all, this first one here is probably our most common. This assist volume control, ACVC. This is what we're giving to our patients that we intubate. We've got them sedated. We're trying to take over all the workload that we can from those lungs. This is going to deliver air at a set rate. We set the respiratory rate and we set the tidal volume. So we're saying you're going to breathe 20 times a minute and you're going to breathe 250 cc's every single time. We're controlling everything. The machine will force that inhalation if the patient doesn't take a breath on their own, and force spontaneous breaths because these patients can still wake up when they're on this mode. That delivered volume does not change. It's not going to adjust for when the patient takes a breath. If the machine senses that the patient took a breath, it's just going to give that 250 cc's. Now, we do have machine triggered pressure modes, and this is known as pressure control. And this is where we're setting the rate. Anytime we have a set rate, it is a machine triggered mode anytime. If we have a set rate, we are saying that the machine is determining how many times a minute that patient breathes. But instead of a set tidal volume, we're going to use a set pressure and say, I'm not going to tell you to take 250 mLs. I'm going to give you 10 or 15 of pressure, and your tidal volume might vary in response to that. This is good for patients with decreased lung compliance who are specifically at risk for that barotrauma, that we don't want to just force a certain amount of air. We want to give the lung the ability to kind of respond to the pressure being introduced, and it's just going to stretch as much as it's able to and take as much tidal volume as it can, instead of being at risk of being forced to take a certain amount of air. Next, we've got our client or patient triggered modes. We have patient triggered volume modes. This is pretty rare, I'll say. Volume assured pressure support ventilation. This is when we are delivering a set tidal volume during spontaneous patient triggered breaths. So we're not setting the rate, but when the patient goes to trigger their own breaths, they're awake enough to trigger their own breaths, it's going to deliver that 250 mLs every single time. Very, very rare. This client triggered pressure mode is very, very common, and it is our weaning mode on the ventilator. It's known as pressure support. It's going to deliver a set pressure during inhalation, and the patient is going to trigger their own breath. Again, it's very common in weaning. We'll make that pressure setting pretty low. We still hold on to a little bit of PEEP, usually around 5, and we'll say this patient is now on pressure support of 5/5, which means we are just supporting their inhalation with a little bit of pressure. We're going to give them 5 of pressure and 5 of PEEP. So we're really just going to keep everything the same. They've got just a little bit of pressure to help them breathe through the long tube that's in their mouth that we normally don't have to worry about. So we'll give them just a little bit, and they're responsible for maintaining their own tidal volume, and they're responsible for maintaining their own respiratory rate. And that's why it's a great weaning mode. Okay, another significant mode that I just want to touch on real quick is SIMV, which is synchronous intermittent mandatory ventilation. This is pretty common in the ICU setting as well, especially if you're working in a post-op unit where a patient's coming out of surgery. It doesn't really fit into any of the categories that I mentioned on the other slide. It's a mode of its own. And the reason for that is it responds to the patient. So it has settings for when the patient is really sedated, and it's going to act like ACDC. It's going to give a certain volume at a certain rate. Now, as soon as it starts to sense that the patient is taking breaths on its own, it's going to adjust the settings a little bit. It's not going to slam the same amount of volume into that patient as it would if we were on ACDC. Those spontaneous breaths are treated differently than ventilator demanded breaths. That ventilator adjusts for patient respiratory effort. This is really important. It makes this mode a lot more comfortable because if you think about how you breathe, some breaths are really big, deep breaths, deep sighs, and other breaths are just normal, small breaths. And our tidal volume changes really wildly from breath to breath. And SIMV allows for that a little bit better and makes it more comfortable than some of our other modes. Now, what are some complications of invasive ventilation? We can have lung injury, ventilator-induced lung injury. This is where we cause damage to the alveoli, typically from barotrauma, and air is then going to leak out of the alveoli, typically into that pleural space. We can actually give a pneumothorax due to a lung injury from the ventilator. Gastrointestinal impact, air enters the stomach during intubation and throughout their ventilation process. We can see a risk for vomiting due to gag reflex stimulation. That tube is sitting in that gag reflex area continuously. So this patient might feel nauseous and might vomit while they're intubated. That would not be helpful for aspiration prevention. Dysynchrony, this is when the patient's breathing pattern and the ventilator pattern are not aligned. So the ventilator delivers their breath, and while the ventilator is still delivering a breath, they take in another breath. They're just not aligned. So to fix this, we either need to switch this patient over to a full spontaneous mode if they're awake enough and we think they can handle that at this moment, switch them to a spontaneous mode to just allow them to control their own respiratory rate instead of being slammed with breaths when they aren't ready for them. Or if we're not at the stage that we can do that, we need to sedate this patient more. We need to kind of kill their own respiratory drive and allow the ventilator to do what we want it to do. Cardiovascular impacts are pretty significant with our ventilators. We are increasing our intrathoracic pressure by having the patient on a ventilator. This is going to compress our vena cava and cause reduced venous return to the heart, which can reduce our cardiac output. Ventilator-associated pneumonia is obviously common. Position, we want to keep our head of bed 30 to 45 degrees. And then do frequent oral care. And this is usually, I mean, hospitals care a lot about their VAP protocols, which is really, really good. ICUs are working very hard to minimize how often a patient is getting a infection from a ventilator. So that's encouraging. We want hospitals to be that way. I'm going to close out here with ventilator weaning. So we eventually need to get this breathing tube out. We need to get the ventilator off, right? So how are we going to go about doing that for our patients? We have a pre-weaning stage. So we're assessing our patient for readiness. And this is multidisciplinary. So first of all, do their lungs look better than when we put the breathing tube in? Have we fixed anything? Is their neurostatus adequate? Are they awake enough to protect their own airway, to take enough breaths per minute on their own? Is their cardiac function stable? If we are having significant hemodynamic instability, taking a breathing tube out just adds another variable to that whole status of that patient. And if the hemodynamics are not looking great, we're going to wait to extubate until we can get that a little bit more under control. We want to control as many factors as possible when we're hemodynamically unstable. Is the fluid status stable? So does this patient still have a lot of fluid on their lungs that's going to make breathing on their own very difficult? Do we need to do another day of diuretics and get fluid off their lungs before we pull this tube? So we're assessing all of that before we even decide whether we're going to wean this patient. During the weaning stage, we'll initiate our wean trial. So this involves changing our ventilator setting to decrease the support. We're going to make the patient trigger their own breaths, and we're also going to reduce the amount of inhalation support that we give so the patient is more responsible for filling their lungs with air on their own. Trial times are gradually increased. So we might even just start with a 10-minute trial and go up to 30 minutes and then an hour. And we want to allow for breaks as these trials can be very exhausting to the patient, especially if they've been intubated for a long time. What does it look like when a patient fails a wean? Well, first of all, I'll talk about what it looks like when they're successful. If a patient's successful, we see them initiate sufficient breaths. So they are initiating a rate that is sufficient, as well as pulling tidal volumes, sufficient tidal volumes, similar to what they were pulling when the ventilator was doing more work for them. And then the respiratory therapist is going to do a lot of pulmonary function tests to assess for if they have a cuff leak, is their trachea not swollen on the tube? Are they able to follow commands and cough and deep breathe on their own? They're going to do some of those tests, and so will we. Failure to wean is going to be, we switch them over to that lower setting, that decreased support setting, and they get really tachypnic and anxious because they're going back into respiratory distress. They're not able to keep up with their oxygen demands without the assistance they were getting from the ventilator. So we're going to see tachypnea, hypoxia, anxiety, use of accessory muscles, and that heart rate and blood pressure are probably going to be elevated, indicating that anxiety that's present. As soon as you notice those symptoms with your patient, you want to flip them back to their more supportive ventilator mode, let them rest, and deem that wean trial a failure. The CCRN does care about recognizing those symptoms of failure to wean. So definitely try to think through your own experience when you've seen patients not be extubated due to a weaning trial. Those are the symptoms that you're going to see with those patients. Okay, I didn't get to chronic conditions today, but that's okay. I think we talked about the main things that you're likely to see in the ICU with our respiratory patients. On Thursday, we are going to do a respiratory part 3. And this is going to be at 12 p.m. Central Standard Time. So it's going to be an hour before it was here today. And we are going to talk about pneumothorax, thoracic surgery. What else are we talking about? Oh, pulmonary vascular considerations. So pulmonary embolism, pulmonary hypertension. So that is going to be on Thursday. We're not waiting a week this time. So I hope to see you guys in 2 days for that. I'm looking here, Keandra. I'm sorry if I mispronounced that, but thank you so much. I am glad that you're enjoying it. I love talking about this stuff, so that's encouraging. Okay, and I see another question. Can I register for the CCRN exam as an international USRN? That is a good question. I would go to the AACN website and see what they have to say about being international. I am not sure what the protocols are there. They've got a really great Q&A section on their website, so definitely check that out and see if you can get an answer. I'll also look into that too and see if I can answer that better next time. All right, it's about that time. I'm going to go ahead and close down here. This, like I said, is the link um, for the talk next time, which will be Thursday, and we'll just see you then to finish out respiratory, and the next week we will go into renal. Oh, thank you so much, Nyasha. I'm so glad that you learned a little bit. This is really fun content and very relevant for ICU nurses. So I love to talk about it. Okay, everyone, we will see you Thursday.